know what populations they're dealing with. We're out there in the Navajo reservation. There's lots of do's and don'ts. My mom's Navajo. There's lots of do's and don'ts. And I'm doing most of everything she tells me to do. Right? She's your mom. You got to do that. But you learn out there, and those doctors have learned out there, being out in the Gallup for the 12 years they've been out there. You know, patient-centered medical homes. We can go on and on about that, but and we're going to talk a little bit about that in regard to a grant that Dr. McEnany received again from CMS. Where's this guy from? She's like,
Thank you.
You almost got it right. I got a target card for you. IT, just because I put you on the spot. IT challenges, IT compliance. Those EMRs, those EHRs pulling data. Let me tell you something, had they told me. We spend a lot of money on these electronic medical health records. Almost never do they talk to each other. So these guys from IT, they're savvy, right? Are there any IT in the room and the people, so I can hide here before? These are some smart people, right? And they know how to develop a product. And they know how to make sure that you're developing a product with them most often, and especially in an environment like healthcare, because the target is constantly being moved for quality by CMS. And so these IT people, they're half out of their minds like us in healthcare, but they're working with us to develop these products. And these products it's hard to get information out of an electronic health record. It's easy to put information in. It's terrible unless you have really strong qualitative data people that can go in and pull that information out. And then you're fighting for everybody in the community to hire those great data people in your community. And handfuls of them. You know, there's not a lot of them, and we need that data. And you think if we're going to prove to Medicare that we're one of the best in the country, we need those quality data people with us all the time. They're my best friends. I buy them huge boxes of chocolate. Huge! Right? They're like, enough with the chocolate pall. Anyway, decision support tools measuring clinical outcomes. We just touched on that. Friends with benefits, completely inappropriate healthcare, right? And don't ever tell Dr. McEnany I showed that to you. Let's get back to the patient, shall we? Cancer. A little bit of a story. So we're with a bunch of doctors. They're all talking doctor talk. I'm there with my husband, and he says, at the end of the conversation, he says to Dr. McEnany, Dr. McEnany actually says to him, Chip, tell me about that conversation you just overheard with all the legislators and the doctors sitting in the room. And he was like, it was interesting, Dr. McEnany, because everybody's talking up here, and I didn't really hear any patient talk. And she was like, you're absolutely right, and we have to get back to that conversation. We've spent the last 5 years getting back to that conversation. And we do it every single day in what we do. Treatment plans must be clear to your patients and to your team and to the families. And your team must be competent. Help patients maintain their dignity and as much of their quality of life as possible, especially going through cancer treatment. And we have measurements for that. Refer accordingly. We practice with many behavioral health doctors across the state, many therapists that treat just cancer patients going through that challenge in their lives. A lot of them going into it with post-traumatic stress disorder because you just told them they had cancer, and that's a really, really tough road. And many of them have multiple comorbidities that must be considered, and you don't have to go very far to see that diabetes and a number of other disease incidents aligns itself with cancer. So we have to have teams of people that are helping to provide hope and love and compassion and kindness and trust for these patients and their families across the state. Okay, Doctor, how far am I on time? How are we doing? Are you still engaged? Do I need to pipe down here a little more? We're doing okay. Oh, okay. Dr. McEnany was invited to write an innovation grant to the Center for Medicare and Medicaid Services 3 years ago. Dr. McEnany knows nothing about a grant writing. Dr. McEnany came to her team and asked them about this grant, this innovation grant. And her team knew nothing about grant writing, so we hired a grant writer. We failed her miserably. But we've learned enough about grant writing from writing that particular grant so that we could make a difference in our community and know that our model for making a difference had measurable qualitative measures and we could share them with other people. So right now, well, 3 years ago, we got that grant. It was a $19.8 million grant to do what we do at New Mexico Cancer Center and replicate that to 6 other clinics across the state, across the country. Guess what it is that we do different at Maxwell Cancer Center that other places don't? We keep them out of the hospital. We realize that part of providing less expensive care for patients and saving money across the state is if we kept these patients out of the emergency room, if we keep them out of the urgent care, if we keep them out of the hospital. Do the hospitals like to hear that? No, they do not like to hear that, right? That's why they have their own oncology groups. But if we could measure that we could keep these patients out of the hospital, then we saved the health plans money, we saved we saved CMS money, Medicare money, and we had to be able to prove that. And there's nothing like having to prove and pull the data for an agency like CMS. It had to be quantifiable, and we had to prove that we could do it before we even got the grant. And so they let us have the grant just because we had already provided them with enough data, and they wanted to replicate that, and we're replicating that now to 6 clinics across the country. So over 30,000 patients over a 3-year grant period were triaged by 6 come-home practices. Triaged means that the patients call in, they talk to an operator, the operator can make a determination at that point after being significantly trained, right? And they go to the triage nurse, and then the triage nurse determines whether the patient needs to come in for hydration or antiemetics or to see their doctor or for any other kind of acute care that they may need. And that's what we do. The Come Home NMCC practice over the 3-year period of grant had patients that experienced 33 fewer ER visits than in previous year for that year. I should have said that there, and I apologize. The Come Home NMCC practice also saw an average of 22 less inpatient admissions than that previous year. Of course, the hospitals were not happy with this data, but CMS was happy with this data, and we're going to continue to do it. You're going to ask me a really hard question.
Well, I'm going to ask you, what's Come Home?
Come Home is what we named the model of the grant. We had to have a name for it, and they required that we have a name, so we wanted to name it Come Home. Why do you think we picked Come Home? Stay home. Stay home with your family. Is anyone comfortable in the hospital? No. People aren't even comfortable when they come into the cancer center. You should have seen when we had the rheumatology patients coming in for the Remicade down into the infusion room. They're like, I have cancer? Dr. Steyer, who works in the 3rd floor of our building, was like, no, you don't have cancer, but we're going to send you down there for your Remicade. But I don't want to go down there for Remicade. Please don't make me. He was like, no, you're going to love the nurses down there. And of course, once you get them there, they love it, they love the environment, they love the nurses, and they love the other patients. Sorry, I digress. But yeah, that's what we need from home. Go ahead.
From what you're describing, it sounds to me like the Come Home model means doctors with their nurses visiting the patients at their home rather than having them come to the hospital.
Pray that that happens. Pray that we move more in that direction, because I hope we do. And I know there's doctors already working gerontology that are already working and have been working toward that direction in a number of years.
Well, the ideal model then, in my opinion, would be a specially configured RV.
I think so too. You want a job? Yeah, let's go. You help me solve that, because I really think that that's...
I mean, is that really the common practice of these doctors that are caring for these people?
We have some amazing programs and projects working across the state, and everybody's becoming familiar. I hope you are too, or you become familiar with Project Echo, which is funded, which is something that's going through, happened at the University of New Mexico, and that we can get these doctors, even if it's through telemedicine, to do very specific things, utilizing science in the best way they can be utilized to keep these patients out of the hospital. We want them not in the hospital. You know what happened to my mom in January? My mom went in with, diverticulitis and colitis. Sure enough, she goes into the hospital. Hospital shall remain nameless, and she gets MRSA. I almost lost my mom. I lost my dad to cancer 10 years ago. Deacon Paul Sanchez, God rest his soul, and he knows that I'm here doing this kind of good work. Thank God he's watching over me. Because there's people I want to beat across the head and shoulders. You gotta love them what they do there at Presbyterian, but yeah, staph and those kinds of infections, they're deadly. My mom went in and almost didn't come out. I'm the oldest of 8 kids. I would have had 7 brothers and sisters that I would have had to consult. I was not looking forward to that. so we keep our patients who are immunosuppressed